Welcome, everyone, again for session 3 of the MI in July with Dr. Kristen Dempsey. Today's session is Cognitive Behavioral Therapy, CBT, and Motivational Interviewing. I'm Ingrid Severson, your Pacific Southwest MHTTC Project Manager. So happy to welcome you all to today's session. Okay, so we are so grateful to be funded by SAMHSA. Also, we want to be clear that the views and opinions expressed by our presenter is hers alone and don't represent SAMHSA or the agency I work with, CARS. At this point, I want to go ahead and hand over the mic to our presenter, Dr. Kristen Dempsey.
So if you were here the last 2 days, we did kind of a general MI overview, and then we did a bit about MI as a trauma-informed approach. I'll actually talk a bit about evidence-based practice today. And even though the topic is on motivational interviewing and cognitive behavioral work, I'm talking really about kind of the intersection around this, like where might we use MI? Where might we start to think about other types of interventions? And I know y'all are doing different things. Not everybody's doing pure CBT, and even what I present today is just a little tiny piece of behavioral therapy and cognitive behavioral therapy. But I hope again to bring in some of this idea of spirit, how we kind of think flexibly between approaches. Like, when am I engaging with MI, and when am I actually helping to shape and motivate, and move towards change behavior or thoughts? And that's just an example. So you can be using motivational interviewing with a lot of other approaches. And I did spend a little time today looking at just the concept of evidence-based practice. Again, it's something that SAMHSA completely promotes and supports in their work, but I think it's such an important thing for us all to think about and to get really clear on, like, what is evidence-based practice, because it can and it should be practice that's really responsive to the communities that we serve. So it's not something that's just a rigid type of approach. It's something that should be really, again, thinking about all the communities that we serve. So you see me here, and I teach, I do psychotherapy, and I do training, including lots and lots of motivational interviewing training. I'm going to start today with the stages of change model again, and really getting thoughtful about when we might use MI and when we might use CBT, knowing that this is just a guide and we're really thinking more flexibly and trying to use it as a tool, and knowing that in real life, outside of this training room, that we have a lot of variation and individuality of all the different people and families that we see, communities, and that where we might start this whole idea of stage of change might look a little bit different in different contexts. Issue might be shifting back and forth between different stages of change. What are components of MI interventions and those that kind of really kind of overlap into CBT? And I do focus a lot, especially on behavioral therapies and interventions, and when might we use different interventions when in a particular session. And I have different CBT and behavioral therapy interventions that are kind of just like standard building blocks that you might see in a number of different CBT and behavioral therapy types of approaches. So they're not necessarily owned by any one theoretical orientation. It's not exhaustive by any means. But what I did do is I really picked the ones I liked and the ones I found that were most fitting in my experience using motivational interviewing, and how they kind of really help promote the idea of engagement and then moving into behavior change. You might find other interventions, I expect you would, more appropriate given the communities you're working with. Again, different populations, different diagnostic presentations, different issues, different age ranges. But these are some of my favorites. So it's not exhaustive at all. I like to just start off, since I spent some time the last couple of days really getting into, like, what's motivational interviewing. We talked about the definition, and we talked about the process, and all the different types of ways that we use it in terms of skills, and skill-based, and how it might apply. And I'll be talking in general, like, what is cognitive behavioral therapy? And even when we say CBT, we're often not talking about any one theoretical orientation. A lot of types of cognitive behavioral therapies, you know, claim CBT as its own name, right? So CBT can be related to a lot of different types of practices. But we do like to think about some of these ideas of, how the way we are in the world in terms of our thoughts, our feelings, including our emotional affect, maybe even our somatic sensing and our behavior, how they all kind of connect. And I have arrows. This is just a clip art piece I found about thoughts creating feelings and feelings really helping to shape behaviors, and then the behavior reinforce thoughts. But it can go other directions as well. What I think can certainly determine what I do, and what I do in any particular day can impact how I feel about myself, the world, and others. So there's often this back and forth between thought, feeling, and behavior. And I particularly find this aspect of CBT really useful because and really helpful for the folks I work with to educate them on this. Almost no matter what type of approach I'm using, I like to teach this just as general psychology and being in the world. That as we go out in the world, we have different experiences, and these experiences we interpret in different ways. And how we think about it, that impacts what we do, and how we do then impacts how we feel. And really trying to help folks kind of sort this out for themselves, because so many times we have people struggling and being in challenge, feeling as if things are just kind of happening to them. I don't know what happens. This just comes out, and I find myself using again, or I find myself I'm always in these relationships where something's being happening to me, and we can feel just very disempowered. So again, thinking about the spirit that we bring into this, and if I'm integrating some ideas of MI with CBT, how the spirit of MI can really be kind of the fertile ground for CBT as well. Like, I really want to have a compassionate understanding how people come in feeling some disempowered, and how maybe teaching even just some of these ideas can be very empowering. Feelings are telling us something. They don't always make perfect sense, but understanding, like, in what context do we start to have our feelings, understanding like how we respond to our feelings, or how we try not to respond to them, right? Like how they can continue then to impact our behaviors and our thoughts. It's really empowering. So CBT in general is a definition here, is a time sensitive, it's often very structured, present oriented psychotherapy, really helping folks address problems, and teaching people how to modify aspects of their thoughts and problematic behaviors. And again, I'm using some common terms. I don't always use the term dysfunctional. Sometimes I'll use the term unhelpful. I think dysfunctional sometimes comes with a lot of baggage. Sometimes some people find it feeling kind of judgy. So I'll talk about unhelpful. So what I like to do is help people just kind of recognize, hey, we're going through life. We have situations, and often situations that we're in, we can have like automatic thoughts, right? Just something that kind of gets generated. And we have different thoughts depending on our own history, our own context, right? We're all part of a world in which we're floating around and things happen to us. So in the present moment, I am clearly impacted by my history. It might shape how I think about a certain situation, and then how I think about it might determine my reaction. Again, my reaction in turn might impact how I'm feeling about something. Might in fact what I do, for instance, might in fact, just sensations that are coming up in my body. Yeah, so I'm noticing different comments. You're all, kind of coming together in the chat box about, you also have, many of you have had experiences altering your own thoughts, or, recognizing like, I don't have to respond to these thoughts. All really important CBT concepts. So just as a little experiment here, this is one that we use a lot in CBT training and classes. You may have had this before. Imagine a situation. And the situation is, you go, you leave your house, you walk out your door, and you see your neighbor coming down the street, and you say, hey, how's it going, James? And your neighbor doesn't look at you and just kind of blows past you, right? And just keeps walking, right? Like that's a situation. This is our own little thought experiment here. James is mad. James is rude. James is mad at me. What did I do wrong? You know what? Give him benefit of the doubt. Maybe he didn't hear me. Now look at these we're coming up with, right? And thinking of these automatic thoughts. How might any of us have a different reaction to this? So if I'm having a thought that maybe he's nearsighted, how might I respond differently if I think of my own reaction, my own feelings, my own behaviors, even what I feel in my body? I'm thinking, oh, James is nearsighted versus, hey, maybe James has a lot going on versus maybe he didn't hear me. I'm really worried about James. Is he okay? Or maybe he's mad, or maybe James is being kind of a jerk. Like thinking of all those things, right? How might that impact how I react? We all have these automatic thoughts, and that just brings us down a path sometimes, especially if we're not able to stop and say, wait, that's a thought I have. Is that a true thought? How do I know that's a true thought? How do I check out that thought? And how you might, in your reaction level, the level of feeling, behavior, physiologically, how might that have impacted how you react? Okay, yeah. So some people might be thinking that might find themselves being annoyed. Sounds like some folks might be able to extend grace if that's kind of what they're thinking about. Like maybe he's having like a really bad day. Maybe he's struggling in some particular way. Maybe I'd go to work mad or obsessing over this. So I'm thinking about what's wrong with James. What did I do? Totally different, right? And we can see how someone's psychological health could really be pretty significantly impacted, even with this little simple example. So I do want to stop here and just talk about evidence-based practice and why one of the reasons I chose CBT to talk about. I chose other things. CBT and this cognitive triad we just kind of explored here. And sometimes I find there's different things called cognitive triad. So this is one that we're talking about here today, is like how these thoughts, feelings, and behaviors can interact. One of the reasons I talked about it is as an evidence-based practice, it's really solid. It's been researched a lot. It's one of the best standards we have in the field currently. Kind of leading the pack in terms of kind of its consistency, its ability to be manualized and to be replicated. Doesn't mean it is the only thing we use. It doesn't mean it works for everybody, for everyone's problems, right? It's one tool in our toolbox for sure. And there are a lot of other types of evidence-based practices where CBT comes into play, or it's helped inform other types of evidence-based practices. So that's one of the reasons I start with it. Figured it's something that many of us can recognize. And so when I do a lot of work around MI, there's always a lot of interest in how does it work with CBT? And I think, what's happening out there, people in the field are great. I got folks engaged with MI. Now, what's a good evidence-based practice to kind of connect? I'm almost thinking of like connecting a hose, right? If I'm connecting something, what's going to do well in the action stage, and something that is CBT or CBT based can be great for that. And it's used to treat a lot of different things. So many of you are working in the area of some of these disorders, and again, we're always trying to promote strengths when we're helping someone change their behaviors and thoughts and feelings. We really want to help empower them. But of course, how people get to us and how we justify doing treatment is we need to, in our medical models, figure out like, is this medically necessary, right? Do that kind of work. And so, yeah, looking at the list of disorders, probably many of you identify with these. Some of you might have certain specialization in these areas. I specialize in substance use disorder and in co-occurring mental health and substance use challenges. I see a lot of folks who are also challenged with what's called here psychosis, and also with eating disorders. Many of you will be using these approaches, these techniques for some of these approaches as well. And with evidence-based practices, that's what EBP stands for. What we're looking at is we're looking at not just like, oh, this is great. Like there's research, which of course we always want to do. We want to be able to find the best external evidence, to be able to have um, research that is, the most soundly designed, that's really replicable, that we've been able to, show in a number of different populations. If it worked once, it could just be chance, right? But we want to be able to replicate it, preferably replicate psychological research in a lot of different types of communities. So it's not just one, type of group of person being uh, kind of explored or tested with a particular approach, right? And also what's important with evidence-based practice, and that's that little purple part in the middle, when it all comes together, is we also need to have individual clinical expertise. So in addition to using CBT, I know my particular case, I had to do a lot of training in substance use disorder treatment. And I did training in CBT for psychosis, and did training in different approaches for treating eating disorder. And many of you have had other training as well, where we've studied and we've practiced and we've did case formulations and we had supervision, and we were held accountable for being able to develop individual clinical expertise. Because it's not just enough to go to any one training, but it's developing skills and feedback over time, right? So we got those two together. And the third piece that's really, really important are patient values and expectations. And I think this is really critical. It also helps fit into this idea of choice and collaboration, which we were talking about yesterday and the day before, that in order for something to be truly beneficial to any of the folks we work with, people have to be empowered to say no to something if they don't like it. So if a CBT approach is helping someone, it's not just something we're going to do to someone, we're going to explain it to them and just going to see, this is something that we think is helpful for you and this is why. Is this something you'd want to try out? And then we get feedback along the way. And if it's not working, we're going to change course. These are all really important pieces. We just don't want to have something that's just like out of the box that we think might work. Want to be really responsive. So for the chat box, a little chat box exercise, I love my chat box exercises. One of the things I like to think about, and you hear people say this, but I'd like to pause and talk about this idea of, evidence-based practice, or the UPB. Yeah, thanks you for asking about that earlier. Evidence-based practice should be a verb and not a noun. And like, what do I mean by that? Right? If we're saying evidence-based practice, isn't just, a thing, but it's a verb, what do we mean? It's something that we do for sure. It's definitely something that we are really active in. Something that we're doing, that we're very clearly involved in a certain amount, steps, there's protocol, there's fidelity, right? There's action around it. It's ongoing, it's a process. That's really important, this idea of the process, which is, as we're doing it, we're getting feedback and we're getting a sense of like, is this working? Is this not working? Do I need to shift? Maybe I need to be more empathic in certain ways. Maybe I need to be more structured over here. Yes, it takes active learning, practicing, and continued effort. Think both for the person receiving, on the receiving end, and for the practitioner, right? It's ongoing. We're constantly changing to improve. Absolutely. So we're both like wanting to stay in fidelity. Again, what I'm doing today is not something that it's just a brief overview. It's not something where you're getting a lot of this detailed training where you'd be able to do CBT or MI to fidelity. It's an hour and a half training, but it's to get you potentially more interested in doing some things and thinking about some interventions that might be really helpful. But then over time, right, you'd be like making sure that you were doing this evidence-based practice the way it was intended, kind of so we don't drift away from it. But also we want to incorporate newer practices, exactly, that are kind of updated with the research. It's a real process-oriented thing. It's not just something that we pull off the shelf. Rather, we're always considering what's the needs of the individual person, the group, or the family, the context, their preferences. And an important aspect of this, like, how do we know? How do I know that this is really working out for someone? Is that they're giving us feedback and we're asking for feedback. How's this working out for you? Is that exercise that we did that help you shift in a particular way? What other things do we want to be focusing on? As we practice this, Is this making sense? Is it not making sense? And knowing that change takes time, and many times we have to apply something over time, but to help see again this outcome in terms of what's the result of this for you. Um, Many times we also give little assessments, right? We'll figure out like how somebody's anxiety shifting. There's tools for this. There's little screening tools. How is somebody's depression shifting? How is someone's ability to stay focused on a task, or to notice their substance use? All of these things we can check in with over time and see, is this evidence-based practice, is it really working? And how does it feel for someone? And how can I adapt and adjust? And around this as well, I'm kind of doing this little dance back and forth between MI and CBT. I'm bringing in some of your MI concepts as we're talking about CBT to see like where some of the connections are. So there's some really nice connections I've noticed over the years. And again, with this idea of the evidence-based practice and getting feedback and so improving and what are the outcomes, thinking again, are we wrestling with each other here, or are we dancing? And if I'm doing an evidence-based practice, based on how I've been trained and all my practice and what the research says and the protocols, but someone is just not getting it, right? Someone is just not, like, it's, absolutely not working for them. And I want to pay attention to that, right? If I'm doing something and it's like, I don't want to do this homework, I don't want to do this practice, I don't get this, what we're doing, it's not helping me, then that's the evidence-based practice needs to be questioned, or it needs to be questioned what we're doing here, or like what's the next thing that we need to do? How do I adjust this? And the nice thing about something like cognitive behavioral therapy, for instance, is that we have different options. Again, we don't have to be using something that's a really rigid protocol. We can look at different types of interventions. If we're moving and we're dancing together and being in sync, then we're going to be really feeling, okay, this is really what evidence-based practice is about. It's about doing what works and I'm trained to do. And that's really, and that's important, because if I'm doing evidence-based practice and someone's feeling like this isn't relevant to my culture, it's not relevant to like how I am in the world, maybe the way I identify in terms of my age, my gender identity, like all these different pieces, then we need to question that or figure out like what else might work, or how might this be used in a way that feels relevant for the person we're working with. So again, it's about this intellectual and cultural humility that comes into play with this work as well. Again, if I'm thinking of MI and CBT, here's our stages of change that you've been kind of reviewing over the last couple of sessions. It's so important. And I talked about last time about our motivational interviewing being such an important piece in our pre-action situation, depending on which issue. So again, for pre-contemplation, contemplation, and preparing, right? Where I'm thinking I want to do something different, but I'm not quite sure, but I'm open to coaching and planning. And again, with the motivational interviewing, you see the green arrow there. It's so helpful for all the ambivalence, right? All that process work you're doing about exploring and reflecting and listening and affirming and building up change talk might help you move into preparing, getting, you have all these things you want to work on. So what do you think you want to do next? And when someone's actively in a place of wanting to change, right? That's where we really have a great opportunity to really start to think about how we can start to use something like cognitive behavioral therapy or some of the other evidence-based practices you told me about earlier in the week. So again, if your CBT is your thing, wonderful. But if it's something else, especially something where you may have a CBT connection, we're going to be using that really more specifically in the action stage. So this is just a little review from yesterday as well, which is all of this work here, the engaging and the focusing and being evocative about what's important for you, what would you like to focus on, collecting change talk, into planning, what do you think you'll do next? And I have this little door at the top of the stairs, right? And to me, that's the door into action, right? That's the door into potentially CBT. So this part down here with my cursor is, and all these are steps, the motivational interviewing steps up to maybe the CBT door, right? And there are times too, even when someone's engaged in CBT, Maybe someone's coming in and they're working on thought records and they're really examining their cognitive processes. Because I've noticed that they have some really difficult automatic thoughts that put them into really blue moods. It makes them, very distressed, and they find that when they alter their thoughts, they find it helpful. It gives them some relief. It's great new perspective. Maybe we're doing that for a couple of weeks, and they come back, a couple of weeks later, and it's like, I'm not sure if this is still working, or I have something else that's coming up and I'm thinking about a slightly different, and we might re-engage, right, in the motivational interviewing kind of way about what's your new target. So before, you're really targeting some of these negative thoughts. The CBT is really helpful. But now I hear you say that you find yourself sometimes just isolating for no apparent reason, and you're really concerned about that. And that might be contributing to your blue moods. So, is this something that we might want to explore here? So, just like we can go up and down the stairs in terms of engagement, even when we go up the stairs and we're in action and we're doing some really nice work in CBT, there's times we might start back out the stairs again because we have a new target. We have something else we're looking at. And here's another thing I wanted to put out, just again, as you're thinking about cognitive behavior therapy and MI, that there's some common factors between the two. Right? And I've already started to talk about some of these, but I went through and very intentionally kind of pulled some of these out, that if we talk about like things that we often train around, like when I'm training you, I'm thinking about any particular practice, like say motivational interviewing. I'm always thinking about what's the KSA. Um, and the KSA is a knowledge, skills, and attitude. So what are the knowledge, skills, and attitude that you need to have in order to do MI well and in order to do CBT well? And there's some that are distinct, to be sure, but there's so many that overlap. So for knowledge, it's really great to know about the stage of change model, because now you have a good idea about when to use MI, and when someone's in action, that's why I start using CBT. There's also this idea too of dialectics, and some of you might be familiar with dialectical behavior therapy. But what I mean by dialectics here is kind of the same thing, which is really, when do I continue just to listen and reflect, use my reflective listening skills, and just allow someone to be in the status quo, right? If even with someone who's actively wanting to change, there's these moments of like frustration, right? And these moments of, I'm not sure if this is going to work, and I'm just hurting right now, or I'm just really sad. And we're not going to force them into doing a thought record at that moment. They just need to be listened to, right? And so I want to balance that reflective listening when someone is in that moment, as well as being able to look at, okay, what's your next step? Where's your action? So we're often balancing this idea of the status quo and change, often between both CBT and MI. Sometimes we balance strategies, which means sometimes I'm being more reflective and just listening to where they're at on the level of emotion. Sometimes I'm more behavioral. Sometimes I'm helping you thinking more in the cognitive space. So in all these different ways, we might be balancing our different strategies. And in terms of skills, the reflective listening, open-ended questions, affirming, and reframing, which is finding a different perspective on something, these are all common skills that you do in both MI and CBT. The attitude that really helps with good CBT also really helps with good MI. And you'll notice it's the spirit of MI, but we really want to bring that spirit into CBT as well. So in this way, it's really nice because you can think, well, wait, there's some commonalities here. It's not like I have to do MI, and then when someone gets to action stage, I have to make a hard right and go into CBT and have it feel totally different. Not at all. In fact, one of the developers of motivational interviewing actually a long time ago, actually considered it, MI and CBT not being the same thing, because MI is more guiding and CBT is more directive when someone's in action. But they're kind of like cousins. They have some common factors, just like, I have some common genetic factors with my cousins. Okay, we're related, but we're not exactly alike. You know, we kind of do some different things. I like that metaphor. Both CBT and MI is another common piece. They're both, was more of a comment, right? They're really both present focused kinds of interventions. And that's actually a kind of important thing to really recognize because people's past stuff does come into all of our work, and sometimes people just will start to talk about the past and want to kind of process it a bit. And you all have different styles around this. I mean, I like to give folks a little bit of space to talk about something maybe they're grieving or they just need to share it, need to have someone in presence. And then I do start to think about like how is that past material kind of showing up right here, right now. So there's a difference between CBT and MI, and MI is actually generally less directive. MI is more guiding. So I'm starting where someone's willing to start, and I'm again listening to their talk and listening for change talk, kind of gradually moving like, oh, I'm hearing you say there's a reason to do this. I'm hearing you say that you really need this and taking some steps. And we gradually move into maybe a place of action. And then when we're at that place of action, that's where we can start to use CBT protocol, which is generally more directive. Where we have an agenda. These are the things we're going to work on. And here are some interventions we're going to do. And we're going to try them out and we'll do homework and we'll come back and report on them. So that's pretty directive. The great thing about it is it does give structure, to work. So that's why I think you have some great outcomes. That's a certain structure. But the downside about CBT, again, this doesn't fit for everyone at every time, is that folks have to be able and willing to engage in the structure at the time. Here's another thing I like to think about too. Yeah, is that CBT are like building blocks that build like individual bricks that build new learning. And what I like to think about, because you might be using like CBT interventions while you're doing DBT, and you might be doing some CBT interventions, say if you're doing some skill development, maybe if you're doing something like art or something, and you're doing all these different types of therapeutic approaches, and often cognitive behavioral or behavioral interventions will be a part of it. So I have here my little diagram. I have behavioral rehearsal and thought record and people monitoring or noticing their activities. Contingency planning is like when I get rewards or I self-reward for having achieved something. So I like to think, yeah, we learn kind of new behaviors. We practice new behaviors and having new thoughts and noticing and tolerating our emotions. That is so much new learning. It's so wonderful. But you'll notice I put there for the grout, like all of our micro skills that we learned in motivational interviewing. Because as I am setting up, doing a thought record, and I'll give you some examples of these in a few minutes, or as we're doing activity monitoring, like I am continuing to reflect, be curious, ask open-ended questions, affirm someone's ability. So what we're doing again with these micro skills is that we're engaging, right? Moving from pre-action to action, we're building the relationship, and we're providing safety and providing motivation. So we're moving folks along from the pre-action work into action, getting them prepared, and thinking about what we were talking about yesterday. We're doing it in such a way that we really help, build safety and resilience. It's very trauma informed. Again, thinking about like what are we doing then in terms of those micro skills. We've reviewed all of these yesterday, and over the next 3 days, today and the next 2 days, we're going to practice some more of these skills. We practiced reflections a little bit yesterday, and today we're going to do a little practice on the ask, offer, ask. I put that one in today's skill set because it feels like it's more kind of related to some cognitive behavioral types of work. So again, I explained these yesterday, but just in case you weren't there, affirmations when we're noticing strengths. Reflections is when we're doing active listening and mirroring back someone's content. Open-ended questions is when we're opening the door, we're asking a question in order to get a narrative set forth that we can then respond to. Summaries is when we really collect information. It allows us to collect and link and move on into process. And finally, the elicit, or the ask, offer, ask, is how we give information and advice with the permission of the person that we're working with. So it's how to be really respectful of boundaries. This particular response really helps us also transition in some ways from MI to CBT. It's not the only thing we do, of course, but it's an example of that, in that once we get to a place of someone being willing to look at something, like in the planning stage, if we ask, you have all these reasons and needs and ideas around change, what would you like to do first? Maybe someone says, I'd like to work on, dealing with my overwhelming emotions that come up when I see my ex, right? That allows us, okay, I just asked and got that piece of information. And now I can offer some ideas of where we might start, or I might say, where would you like to start with this? It's totally up to you, but these are some particular options. I have some ways that we could look at your thoughts around this, and different ways we could look at your behaviors. Then we ask again, what do you think? Where would you like to start? So we give some people choices about where to begin. And that's where this is almost like what I call like a hinge intervention. Like, it allows us to kind of hinge into a number of different types of options, because we are asking people where they're at, seeking their collaboration, giving some ideas, and then stepping into maybe a more active approach. And it allows us to make that transition kind of nicely from MI to CBT. So I got another exercise here I just kind of wanted to throw in. Again, you're thinking about, MI, guiding, pre-action, CBT. Okay, it's more directive, and now we're doing something. We're going to have interventions, which Kristen's going to show us in a minute. If you're in the world with somebody and you're out there working with them, like, how do you know, when am I using MI? When am I using CBT? So I did this little thing, it was a little exercise, where I kind of throw out here, MI or CBT? And it's not, again, it's just an exercise. It's not totally comprehensive, in that in the real world, you would have a lot more context with which to answer some of these questions. But here's an example. Someone says to you, I guess I should think about going to those meetings. I'm not sure where they're happening or if I can get there, right? So I think, what would you say? Some people are saying like MI. Yeah, what would you say MI in that one? Okay, you're seeing some ambivalence. Okay, yeah, there's definitely some ambivalence. Explore the contemplation. Yeah, this idea of like people being like, well, I guess I should think about going to those meetings. I'm not sure how I can get there. Sounds like we might have someone who might become more potentially the planning or preparing stage. Preparing, or are they contemplative? And we can debate for like hours sometimes on some of these statements. But let's just say they're more preparing. So this might be a great time to be like, okay, so one of the things I'm hearing is that potentially if you had an idea of how to get there, you might take the next step. So it might be a place then we could do this ask, offer, ask, and see possibly, again, some MI, ask, offer, ask, just getting into getting some action started. I do not know why the principal had me coming to see you today. I don't have a problem with focusing in class. You're all putting out MI. Why are you putting out MI? I'm saying they're pre-contemplation. I'd have to agree with probably pre-contemplation, because they're not really a customer. Like, I don't think I have a problem, right? I actually say that I don't have a problem with focusing in class. Now, again, they're sitting with us for a reason. So I might be curious about, so why'd you come? Well, I had to. What do you mean you had to? Like, what would happen? Well, I'd be in detention. I don't want detention. Oh, okay. So you're not really sure, but one thing you do know is that you want to stay out of that detention room, right? So maybe that's a place where we could start to have a conversation about staying out of detention. What does that mean? And just having conversations, again, will often probably lead to like maybe some other things that are going on for this person. And again, I hope the principal wouldn't necessarily have a child in detention for not wanting to go to counseling, but that might be what they're thinking, right? It may not be in actuality what would happen, but just examples. Number 3, I occasionally take my medication. You know what? I'm not sure if they even help me. Maybe they do for a few months. A little bit confusing, because what you see there, right? You actually see someone kind of doing action, right? But they don't always do it, and they're questioning. But like, oh, again, yeah, you definitely have this sense of contemplation. But there has been times when they've actually taken the medication. So there might be a little. I would probably start with some aspect of MI just to get a sense of their sense of ambivalence. But I would be really curious though, right, about like the times they do take medication, like what kinds of things they're thinking, and maybe there is a link if they felt the medication was really helpful to be like what it is that happens when you do take it. I would probably, just to let you know, if I'm thinking of action, again, I'm going to collaborate. I'm not going to tell anybody what to do. Is actually an action piece might be something like consider is making sure we actually talk to, maybe the action piece is going back and talking to the doctor, right? There's a reason why you're ambivalent around this. Maybe it's not quite the right fit, right? I don't want necessarily want somebody taking the medication if it's not even, they don't think it even really helps, right? So I'm thinking of maybe the action piece is getting more assessment. You have that can help me manage my anxiety. I can barely get through the school day. MI or CBT? That one is a little more obvious, right? So now we're gonna kind of move into action a little bit. And again, I'm really aware of the time, so I'm gonna probably move a little bit faster through some of these slides, but because I want to give you a chance just to have a conversation together about an example, just to get some practice. So the second and third wave of cognitive behavioral therapies, really CBT, as we know, it kind of the second wave actually probably developed more in the 50s, 60s, and 70s. It continues today. The approach that we often think of CBTs was developed by Aaron Beck, and his daughter Judy Beck is still really driving it, which is about addressing automatic negative thoughts. So things that you see like a thought record, where we look at our thought and say, hey, how do you know that that's really a situation? Like, what's your evidence around this? What are some alternative ideas? Really came a lot of what we call like the Beck approach. And then there's also Albert Ellis. And by the way, Aaron Beck, he just passed away, I think last year at the age of 100. Ellis also passed away in the his late 90s. So they lived a very long time, contributed a lot to the field. And he spoke a lot about irrational thoughts, like helping people recognize and I guess self-judge particular thoughts as being rational or irrational, and really challenging those as they see fit. And both are dealing with changing thought content, like how do we go in there and really start to change what it is that we're thinking or challenging the thought. The third wave of CBT, which is more related to, like, say, dialectical behavior therapy, acceptance and commitment therapy, some aspects of compassion focused therapy, is more about changing relationship to thoughts, more about how we think versus what we think, and developing values. So it can be more about, instead of thinking like, oh, what's this thought I think about my neighbor who doesn't like me? What's an alternative thought? Maybe my neighbor's having a bad day. With more of the third wave CBTs, it's more just being able to notice that I'm having this thought about my neighbor. Doesn't mean I have to change it, but I'm just really aware of the fact that I have these particular thoughts, and thoughts are just thoughts. They're not necessarily fact. And being able to live with our thoughts, but develop a new relationship with them. And that actually tends to work really nicely for a lot of folks, because many of us, it's really hard to actually change our thoughts, but changing our relationship to them, this is a way of having a different approach or relationship. So these are all very much separate trainings. We get into a lot of different details, but I just wanted to give you some examples, again, of things we can work with. This is something you might see. It's kind of based on what we did before. If you're doing like a real traditional like case cognitive conceptualization, that you would actually start to look at what are some relevant life history that's actually relating to the present moment. And then we start to look at, different situations that emerge. And then when situations emerge, what kinds of core beliefs start to show up during those episodes? What are some, attitudes or rules or ways that people, assumptions that people make about themselves or world and others when a certain situation comes up. So for instance, if I'm thinking of my neighbor again, not blowing by me, maybe I have some core beliefs that I'm a worthless person, and I don't feel particularly loved because of some poor attachment issues I had earlier in life. And maybe, my intermediate beliefs, attitudes, it's like, rules, it's like, just look away, don't talk, because you know what? you don't want to be rejected even more. So it's not even worth trying to check this out with my neighbor because I'm not worth it. I mean, my coping strategies to go home and hide, right? Or to go home and cry. These are really sad situations, right? And we can help people kind of unpack how different situations start to lead to some of these like automatic thoughts and help them start to see patterns. And with the awareness of some of our core beliefs and some of the automatic thoughts that shift to that, practice different thought patterns, practice different behaviors that help break us out of some of this rigid, both cognitive and behavioral practicing, right? Yeah, catch it, check it, and change it. I really love that. The 3 C's, exactly. And so again, at first, we're also thinking this is kind of a very kind of quick and simple a way of thinking about this, knowing that I just had a minimal amount of time, is when we're doing some CBT types of case formulation, like we do want to consider what are people's diagnoses and their presenting problems, what potentially is causing presenting problems and what might maintain that. And that in relationship to that, again, kind of going back to this little piece here, if you will, like where do these things start to fit in with this, right? What kinds of situations are coming up that are helping to impact some of these problematic maybe thoughts and behaviors and assumptions that are maybe really held together by a core belief that just keeps things going. And I think you're absolutely right. And like clients I find are very they get this. We show folks this stuff, and again I try to show like these little cognitive triad pieces and just even kind of writing on whiteboards, like how this might be related to this. And I find that folks find it very relieving. Like, no, I'm not, there's not something wrong with me. This is kind of a normal way of thinking given what I've been through, and I can do things to shift this. Sometimes we also talk about Beck's cognitive triad for depression, which is, thinking of our kind of presenting problems. This is a really common one that fits in with, like, say, a depression or maybe an anxiety diagnosis, where people have negative views about the world, about the future, and about oneself, that really start to help anchor in some of these really problematic ways of thinking. So talked about this yesterday too, again, for thinking about people's history, how that starts to potentially impact how some of these core beliefs get started. Clearly, some of the social, emotional, cognitive impairment, that's where some of this cognitive behavioral stuff can start to set in. And then with that comes my at-risk health behavior, right? So if I'm thinking that there's no reason why my neighbor should talk to me and I'm a worthless human being, maybe I also have some problematic health behavior in addition to isolating. Maybe I'm also drinking at home. Maybe I'm also, cutting on myself, right? I mean, there's all different kinds of things that we start to see with people that we can start to make links, based on the history, based on some of these thought, social, affective patterns that have developed over time. So you've already seen this a little bit. And again, just I want to put the slide in here just so you can see it again and get another aspect of explaining the links. And I actually want to get into actually going into interventions. I'm going to go through some of my favorite ones here, and we do this in MI, and I think it relates really nicely to cognitive behavioral work. Is when you're going up those steps and we move from engaging to focusing. Again, I know I've gone over this a lot. That often on the focusing step, because we've had a little bit of engagement, it's a great opportunity to summarize with someone. Like, I'm hearing that you have these things going on for yourself, that you're really worried about feeling depressed, that you have this concern about being lonely, that you're not sure how to talk to people. Given all these things that we talked about, like, what kinds of things would you like to spend our time talking about? And so what we can do is we can actually start to write into these little circles, loneliness, right, isolation, right, and sadness, however they say it. I like to use their terms. Because what we can do is, even if someone's not ready for cognitive behavioral interventions, I can say, okay, now which of these do we want to focus on today? That's the one I can say, tell me more about it. Again, we're trying to develop change talk. And as we summarize change talk and we get to that place of planning, we can be like, okay, I'm hearing you say with the sadness, you're really struggling with it because it's keeping you from people you love. you find yourself isolating and you cry every day. What do you think you'd like to do next around this? What would be helpful? And we can gradually kind of move into that place of maybe being willing to do something. So the circular agenda is a great organizing tool for this. That's right. It gives you a lot of time to kind of go back to. If people get off track, you can return to it. You can get reoriented. Again, this is an MI technique, but setting an agenda is also common in cognitive behavioral therapy as well. I talked about this change talk a bit over the last couple of days, but you might be thinking about, well, okay, so we were talking about change talk in the evocation stage. I know we can reflect on it, but what if someone doesn't actually start saying anything around change? We can actually start to elicit it. We can ask for these evocative questions, or tell me more about what you're saying in terms of this need to connect with other people. We can ask people, imagine you did change, how might your life be different in 5 years? Looking forward, if when you 5 years ago when you weren't drinking, how is your life different? We start saying, what's the best case scenario if you did change? Let's talk about the readiness ruler in a few minutes too. About you say you change just a little bit. What would that look like? What are your goals and values? How does changing help you meet some of these goals and values? So all of these things allow people to start to move away from the status quo and move toward, again, we're kind of moving toward this action phase where we can really start to use the CBT. Rulers are really helpful. So we can always use a ruler with like a scale of 1 to 10 and ask people, like, where are you in terms of your willingness to talk to people? Where are you in terms of your willingness to start to do something about your depression, let's say? And if they say, like, oh, I'm a 5, what would help you be a 7? Right. So we try to help them get some ideas about, well, if I tried talking about it a little bit more, maybe if I went out a little bit more, and we start to write down like what would help them feel better, what would help them start to engage. And we can also ask, like, how confident are you in your ability to manage? What would help you be more confident in terms of doing something about your depression? Well, I'd feel more confident if I could, maybe practice some skills and see if they work for me. I'd be more confident if I had more information about depression. And then we start to write these things down, and that can become the basis of where we get started in CBT, right? We're already getting a little idea of, like, these are some things that people are willing to do. So maybe they are willing to do some behavioral practice. Maybe they are willing to do some, psycho ed. I could show them that. Maybe they're willing to do coaching. And then there's also readiness ruler. Sometimes people really want to change, they're confident, it's important to them, but they're just not ready. And sometimes we can ask that, like, in terms of managing your depression, what would help you feel just a little bit more ready to do that? And that also gives us more information. So what we're trying to do is we're really trying to kind of negotiate some willingness to change, right? Because it's really, really difficult when someone is just talking like, well, I know I got this thing, I know I need to change it, but I don't know. Like, that can be a really difficult place, right? Where someone knows they have reasons to change, it's important to them, they're concerned about it, maybe they've done a little bit. We want to just kind of nudge them to that next place of the willingness to try out some techniques. I'm going to move into some change strategies now. One of the things we do in CBT, again, is we do set agendas, and that allows us to have a certain amount of focus. When we're doing that circular agenda with MI, that's also a way of setting a bit of an agenda. It's not as detailed as a CBT agenda, but there's some correlation. So I just like to say again about commonalities. And if you're trying to sort all this stuff out, like, what am I trying to do? We're really trying to engage people, help them talk about change, build their confidence and ability to do something about what they want to change, and then help them with some focus. And you help people focus a number of times and going back to focus, because we get unfocused. And agenda setting, which a lot of CBT therapists do, like every time we do a session, kind of refocus and kind of go back to what's on our agenda today, that really helps people get set up for readiness to change. So I think what I'm going to do here is I do have some behavioral strategies for us to actually get a chance just to try something together. And so have some instructions here about the elicit, provide, elicit, which I showed you about. This is the motivational interviewing intervention, but it works really nicely in the context of, again, moving someone into some component of cognitive behavioral therapy. And I gave you a little prompt here. You're working with a 50-year-old cisgender male student who is feeling hopeless that he will ever catch up academically after missing a year and a half of school, right? So this is, kind of a later pandemic kind of situation. And cisgender, by the way, means person identifies with the sex assigned at birth. For practice being taken on that particular personality, that would be great if you want to role play. Thinking about, okay, what would be a first step? Like, how would I ask this person for permission? What kinds of words would I say to say, hey, is this something you'd be willing to talk about? I'm hearing that you're really struggling. Like, what kinds of things do you need? That's the first E. And the second would be, then what do you actually offer this person? And the third step is actually checking in and getting feedback, right? So given that, I gave you this little piece of advice, what would be some feedback? How's this working out for you? And so I just want to give you a chance to be able to have this conversation. So the slide you use is this slide here, right? And just imagine, again, with this, I gave you this prompt. It doesn't have to be this prompt. It could be something else. It could be your own real life issue that you're talking about. Maybe you role play it. But just with this idea of let somebody talk or talk about the situation, have somebody actually ask what somebody needs, offer a little bit, and then ask again for feedback. Just see what that feels like.